So next we'll start with the immunodeficiency disorders. So under immunodeficiency disorders, we have primary and secondary. So the primary immunodeficiencies are further classified into innate immunity disorders and adaptive immunity disorders. Under secondary immune deficiency disorders, age is going to be the most common cause. Okay. So now we'll say about the primary immunodeficiency disorders. So the examples of the innate immunity disorders under the primary, we have already discussed it under the inflammation chapter. So those were leukocyte adhesion defect, Shediac-Higashi syndrome, then chronic granulomatous disease, MPO deficiency, complementary deficiency, and then complement regulatory proteins deficiency. So all of this we had dealt it in inflammation. So now we'll be seeing about the adaptive immunity disorders only. So under adaptive immunity, primary immunodeficiency disorders, we have some severe combined immunodeficiency, common variable immunodeficiency, Bruton's A-gamma globulinemia, DiGeorge syndrome, hyper IgM syndrome, IGA deficiency, X-linked lymphoproliferative disorder, and Job syndrome. So let's see one by one. So first we'll start with the severe combined immunodeficiency. So as the name suggests, it is something combined. So it is basically a T and B cell defect. So remember, whenever we have a T cell defect, it is eventually going to cause a B cell defect. Why? Because T cell response, B cell is actually based on the T cell response, right? So only when T cell response is there, you are going to have affinity maturation. T cell dependent response is there, you are going to get isotype switching and affinity maturation of the B cells. So whenever T cell defect is there, it is going to cause B cell defect. So firstly, we'll be seeing about the T cell defects. So severe combined immunodeficiency disorder. So combined means there is going to be both T and B cell defect here. So when both is going to be present, it is going to cause a severe defect. Okay, severe immunodeficiency. So under SCID, we have two types. X-linked SCID and then autosomal recessive SCID. So X-linked SCID is going to be the most common form here. So in X-linked SCID, the mutation is going to be present in the gamma subunit of cytokine receptors. So this, when the cytokine receptors are going to be mutated, there is they cannot respond to the cytokines like interleukins. So one of the interleukins, which is interleukin 7, which is one of the most important interleukins needed for the T cell survival and differentiation. So this interleukin 7 cannot go and attach to this signaling cytokine receptors, because mutation is present. So signaling is going to be defective over here. So when interleukin is not there for signaling, obviously the T cell cannot survive and proliferate. So in T cells number will be decreased over here. But when T cell number is going to be defective, B cell function is going to be defective. But B cell number is not going to be decreased, because B cell number is going to not be affected here. Only the function of B cells will be affected. So in X-linked SCID, we are going to have decreased T cell number along with normal B cell number, but B cell dysfunction is going to be present. And similarly, NK cells will also be decreased in number, because there is going to be interleukin 15 is needed for the proliferation of NK cells. So interleukin 15 cannot act on the cytokine receptor. So again, that will result in the decrease in the NK cell. So when B cells are defective in the function, T cells are decreased in their number, and NK cells are decreased in the number, obviously it is going to result in a severe immunodeficiency. So next type of SCID will be the autosomal recessive SCID. So here it is actually due to a deficiency of an enzyme called as adenosine deaminase. So it is called as ADA. So ADA deficiency is going to be the most common cause for autosomal recessive SCID. So when ADA is deficient, obviously the substrate on which it is acting upon will be accumulated. So substrate accumulation will be present, and the substrate which is accumulated is going to actually be toxic to the T cells. So toxic to T cells, so T cells number will again be decreased over here, resulting in B cell dysfunction as well. Okay, so number of T cells will be decreased, but to a slighter amount, B cell number can also be decreased, but mostly it is the B cell dysfunction here. And this is the first disease for which gene therapy was discovered. Okay, gene therapy was developed for this disease first. Next, we'll move on to the next type of T cell defect, which is DiGeorge syndrome. So in DiGeorge syndrome, you are going to have chromosome 2211p deletion. Okay, there is going to be chromosome 2211p deletion. So this chromosome 2211p, there was a gene called as TBX1 gene. So TBX1 gene is the one which is responsible for the development of third and fourth pharyngeal pouches. So from this third and fourth pharyngeal pouches, normally the thymus, the parathyroids, then the great vessels of the heart, and all of this is going to develop. So when this defective TBX1 gene is present, the third and fourth pharyngeal pouch is not developed properly. So there is going to be defective development of the thymus, great vessels, and branchial arch, which is the parathyroid, forming the parathyroid. So when thymus is not formed, it is going to cause a decreased T cell immunity, obviously. And then great vessels and the heart is going to be affected. So the child will have a congenital heart defect, and along with that, they can also have great vessels defect. When parathyroid is going to be defective, parathormone is not going to be produced. So when parathormone is deficient, obviously the calcium levels of the serum will be decreased, resulting in hypocalcemia and tetany. Okay, so these are the basic features of DiGeorge syndrome. So for remembering this, we have a mnemonic called as catch-22. So in catch-22, we are going to have congenital defects, basically like cleft palate and lip. Okay, cleft lip and palate is going to be present. Then A is for abnormal faces. The kid's face is going to look abnormal. And T is going to be for thymus defect. So thymus defect resulting in decreased T cell immunity. Then C is going to be for cardiac defect. So cardiac defect, especially the great vessels are going to be affected, and also tetralogy of Fallot can be seen. H is for hypocalcemia because of parathormone deficiency as a result of parathyroid developmental defect. Hypocalcemia, that will result in tetany. So 22 stands for the chromosome 22, which is being deleted over here. Okay. So moving on to the next syndrome, which is Bare lymphocyte syndrome. In this Bare lymphocyte syndrome, there is going to be deficiency of the MHC class 2. So class 2 is defective. So obviously the antigen presenting to the T cells will not be proper. So proper presentation of MHC to the T cells will be defective. So the T cells will not be activated properly. So CD4 T cells cannot develop properly, and that will result in the decreased cell mediated and humoral immunity. Because T cell is affected, both humoral mediated will also be affected. So Bare lymphocyte syndrome, remember, MHC class 2 deficiency resulting in both T and B cell defect. Then moving on to B cell immune deficiencies, which is starting with Bruton's A gamma globulinemia. So Bruton's, remember, B stands for B. So B stands for B. So boys are affected because it is a X-linked recessive defect and it is a B cell defect. Both B's are there. Okay. Then A gamma globulinemia. What does that mean? A gamma meaning the immunoglobulins are not going to be produced, okay, or they are going to be either not produced or being deficient. So immunoglobulin G, so gamma is for G. So when IgG is deficient, it is IgG, you all know it is an opsonin also. So opsonization will not take place without IgG. So opsonization is going to be defective. So that will result in specific infections. So normally H influenza, Haemophilus influenzae infections, and pneumococcus. So these are all usually killed by opsonization and phagocytosis. So with deficient opsonization, there is going to be infections with this H influenzae and pneumococcal infections. Okay. So what is the defect in Bruton's A gamma globulinemia is that there is a defect in a gene called as Bruton's tyrosine kinase. So Bruton tyrosine kinase stands for BTK gene. So Bruton tyrosine kinase is defective. So in this case, the B cell precursors cannot become mature B cells. Okay. So normally from the immature B cells, it is the precursor B cells, mature B cells will form, and from mature B cells, plasma cells will form, and then plasma cells will form immunoglobulins. So the first step wherein the precursor B cells are forming mature B cells is going to be affected over this in this Bruton's A gamma globulinemia. So usually the kid is of more than 6 months age. So around that infant age group itself, you will have this defect, and they will present with recurrent sinonasal infections, pneumonia, and then gastrointestinal infections, because there is going to be immunoglobulin deficiency in this A gamma globulinemia, right? So because of that, recurrent infections are going to be present. And here the patient's B cells will be decreased because mature B cells are not formed, and further plasma cells are also not formed from this. So both the plasma cells will be decreased and the mature B cells will be decreased. So when plasma cells are not there, obviously the immunoglobulins are going to be decreased. So decrease in B cells, plasma cells, and decreased immunoglobulin. But as such, the T cell numbers will be normal. While the B cells present in the various lymphoid organs like lymph node, then the GI organ, spleen, they are going to be underdeveloped. Basically, in the lymph nodes, we are going to have this follicles, right? So the follicles, the white pulp for the spleen, all of this is the region where B cells are present. So these are going to be underdeveloped and they are going to appear atrophic. Okay. So in Brutens, it is B cell defect basically. So everything related to B cell is going to be decreased. And as such, you'll have to avoid vaccination with live vaccines like polio vaccine. Otherwise, it is going to lead to poliomyelitis. So remember, B cell defect, you are not supposed to give any live vaccines. And as such, there is going to be increased risk of other autoimmune diseases in this as well, because the gamma globulins are not produced properly. Then moving on to the next disease, which is common variable immunodeficiency. So if you read it in comparison with A beta Bruton's A gamma globulinemia, you're able to understand. Okay. So here again, there is going to be hypogamma globulinemia like that of a Bruton's A gamma globulinemia. But here the defect is in the BAF or ICOS. So BAF or ICOS is the one which is responsible for the maturation of mature B cell into the plasma cell. So this is basically the second step. So in Bruton's A gamma globulinemia, it was early precursors of B cells not becoming mature B cells. In QID, it is actually the mature B cells not becoming the plasma cells, the second step. Okay. So basically, the B cell number will be normal, but the plasma cell is going to be decreased. Okay. And then the germinal centers will actually be hyperplastic in this compared with that of the Bruton's A gamma globulinemia. In Bruton's, it was underdeveloped. But here, as a compensation for decreased plasma cell, the B cells are normal number, right? They are trying to proliferate and they will be hypertrophied in the germinal center. Here again, we are going to have recurrent sinonasal and then GI infections, especially Giardia infections will be present here. Okay. So Giardia, because every other immunoglobulin is also going to be defective. So IgA immunity is going to be defective. Mucosal immunity is going down. So enteroviral infections and Giardial infections are common here in QID again. But the main difference here is Bruton's was a X-linked disorder. So it was affecting the boys. Kids, basically less than 6 months of age, around 6 months of age, more than 6 months of age. But here in QID, it is going to be equal in both the genders, and then it is going to be a child. So elderly, more than the Bruton's age group, QID age group will be there. Okay. So in Bruton's, it was around 6 months of age group, while in QID, it is going to be in childhood. Here again, there is going to be increased risk of cancers and autoimmune diseases. So the next syndrome will be hyper-IgM syndrome. So as the name suggests, hyper-IgM. So IgM is going to be increased, but other immunoglobulins are going to be decreased. Okay, so IgG, IgA and IgE are going to be decreased. So as such, here there are two kind of defect here. So CD40 ligand mutations or CD40 mutations are going to be present. So CD40 ligand was present on the T cell actually. This is going to be X-linked. While CD40 mutations which are actually present on the B cells, this is going to be autosomal recessive. Okay. So with decreased amounts of this IgG, IgA, mucosal immunity will be gone, and then the main IgG opsonization defect is going to be there. So it is going to cause recurrent infections again. And as such, the B cell and the T cell number will be normal here. It is just the immunoglobulin production is going to be altered. So recurrent pyogenic infections will be present, especially in hyper-IgM. You are going to see pneumocystis jirovecii infection. Okay, Giardia most commonly in QID more than Bruton's. In hyper-IgM, you are going to have pneumocystis jirovecii infections. Apart from that, because of this IgM, so this IgM is going to form auto-antibodies and be directed against the various blood cells, against RBCs, WBCs and platelets. So it is going to cause autoimmune hemolytic anemias, then autoimmune neutropenias, autoimmune thrombocytopenia. So together they are going to cause pancytopenia. So pancytopenic picture can be seen because of the autoantibodies which are IgM. So pancytopenia, it will result in the recurrent pyogenic infections again. Okay. Next syndrome will be hyper IgE syndrome now. Okay, and this is called as a job syndrome as well. So as the name suggests, you are going to have increased amounts of IgE. And here the defect is going to be in the STAT3 transcription factor. So when STAT3 is defective, the defective Th17 responses are going to be there, because for only when STAT3 transcription factor is there, the T helper cells will differentiate into the T helper 17 subset. So when defect in STAT3 is there, Th17 responses are going to be defective. So Th17 responses are the one which are needed for neutrophil and monocytes recruitment, right? So this recruitment will not happen properly. So phagocytic cells will not be recruited. So obviously the infected organism is not going to be phagocytized properly. So classically they are going to present with multiple cold abscesses, staphylococcal cold abscesses. So recurrent cold abscesses are going to be formed. Along with that, you are going to have mucocutaneous candidiasis and eczema. So hyper IgE, you have E, right? It is going to resemble like C. So it is going to look like C. So remember, cold abscesses and then candidiasis, and then you are going to have eczema. E for E again. Okay. So you remember these three things in hyper IgE syndrome. Next, we'll see about isolated IgA deficiency. So this is the most common immunodeficiency as such. And here IgA is defective, so obviously IgA producing plasma cells are going to be defective. So something in the class which is going to be off here. So IgA is going to be needed for the mucosal immunity. So with the IgA deficiency, you are going to have lots of respiratory tract and GI infections along with genitourinary. Mucosal immunity is going to be affected. Then also allergy can be associated with that. Various autoimmune deficiencies or diseases can also be associated with that. One important thing about IgA deficiency is that for these patients, you are not supposed to give normal IgA blood. Okay, so whenever they need blood, you are not supposed to transfuse blood of normal IgA persons. You have to give the IgA deficient blood only, because if you transfuse with normal IgA blood, it is going to result in anaphylaxis and it is a life-threatening situation. So the next immunodeficiency disease is the X-linked lymphoproliferative disorder. Here actually the defect is going to be in a protein called as SAP. So SAP is needed for the B cell maturation here. So there is going to be defective NK and T cell activation. SAP is needed for the T cell. So there is going to be NK and T cell defective activation. And when this is going to be there will be recurrent EBV infection along with B cell lymphomas. Okay. So SAP for EBV infections. So EBV infections are causing polyclonal B cell activation that can result in various B cell lymphomas. Then moving on to ataxia telangiectasia. So here it is an autosomal recessive disease. Basically the defect is going to be in a ATM gene. So the ATM gene is located in chromosome 11p. So ATM gene is needed for the DNA repair. So as the name suggests here, the disease is the patients are going to have ataxia, then telangiectasia, and along with that they are going to have some defect in the immunity, neurological defects, and they are prone for developing lymphomas and leukemias and cancers as well. So more often here it is a B cell defect than a T cell defect. Next, we'll see about Wiskott-Aldrich syndrome. So, Wiskott-Aldrich syndrome, the defect is going to be in the WASP gene. And here again, it is a X-linked recessive disorder. So, WASP gene, here it is going to be a triad of thrombocytopenia, and the platelets are going to be small platelets here. So thrombocytopenia along with eczema and recurrent infections is the classical triad of Wiskott-Aldrich syndrome. So remember, Wiskott starting letter is W. It looks like an inverted M. So it is actually having decreased IgM, while the IgG levels are going to be normal, while elevated levels of IgA is going to be there. IgA and IgE will be elevated. But here the T cell numbers will be decreased. Here again you are going to have an increased risk of lymphomas and leukemias. Okay, the main thing here will be decrease in the IgM while the IgG is normal and other immunoglobulins are going to be elevated. So now we have seen about the various primary immunodeficiency disorders. Next we will move on to the secondary immunodeficiency disorders, out of which the most common cause was HIV infection leading to AIDS. Other than that, in bone marrow, if the bone marrow is going to be affected by chemoradiation or any bone marrow metastasis, lymphomas, leukemias, then protein calorie malnutrition, splenectomy, all of this is going to affect the stem cells, so resulting in a secondary immunodeficiency. So let's see about acute immunodeficiency syndrome, which is AIDS. So it is going to be caused by the retroviral infection, which is HIV, human immunovirus. So we have two such strains of HIV, which is HIV-1 and HIV-2. HIV-1 is going to be common in US and African countries, while HIV-2, it is usually seen in India. But as such, if you see in India, the most common strain is actually HIV-1 only, especially group M subtype C. So group M subtype C HIV-1 is the most common strain in India. But if they ask specifically where HIV-2 is more common, then it is HIV-2 is more common in India. Okay. So how do this HIV spreads? We all know that it is going to spread through parental methods and homosexual, especially in homosexual individuals rather than the heterosexual. So heterosexual and homosexual transmission is there. Parental, when they share the needles or needle prick injuries. So the risk associated with any needle prick injury with HIV is going to be 0.3%. While for HBV, it is going to be 30%. Okay. HBV needle prick injury risk is 30%, while for HIV it is less, 0.3% only. And apart from that, mother to fetus transmission, vertical transmission can also be there. So if they see the structure of the HIV, it is going to have two glycoproteins at the surface, which is glycoprotein 120 and glycoprotein 41, which is going to be needed for the attachment of the HIV to the host cell. So other than that, you are going to have a central hexagonal nucleocapsid composed of P24. So inside this nucleocapsid, you are going to see single-stranded RNA, and on that we are going to have various enzymes like reverse transcriptase, protease, and integrase. So between this glycoproteins and the central nucleocapsid, this yellow part is going to be representing the P17 matrix. Okay. So coming to the life cycle of HIV, HIV virus can infect both CD4 positive T cells and monocytes. So based on the type of cells they infect, they are going to be classified as M-tropic and T-tropic. So T-tropic is the one which is going to be called as X4 strain. So X4 strain will actually bind to the CXCR4 receptors, while the R5 strains are going to be attached to the CCR5 strains. So remember, when we are reading about the chemokine receptors, I mentioned. So chemokines were of 4 families subtypes like. So CXCR4 and CXC and CC were some subgroups of this chemokines. So the receptors of this CXC and CC are the CXCR4 and CCR5. So these act as co-receptors for HIV binding. So this X4 strain is going to bind to the CD4 positive T cells, and they are going to be called as T-tropic, and these strains are going to be more virulent compared to the R5 strains. R5 strains will bind to the monocytes, and they are going to be called as the M-tropic. Okay, T for T cells, M for monocytes. Okay. So what happens as with the HIV infection is that once this HIV is entering the body, it's glycoprotein 120 and 41, right? So that is going to attach with the CD4 T cells. So CD4 receptor is present. So onto that, this glycoprotein 120 is going to get attached. So this will result in, along with that, it is going to also attach with the co-receptors, which was CXCR4 or CCR5 based on the strain of the HIV. So this is going to cause a conformational change in the receptors, and that will result in the fusion of this glycoprotein 41 of the HIV to fuse with the host cell membrane. So once this fusion happens, the HIV single-stranded RNA is going to be released into the host cell. So this single-stranded RNA contain the reverse transcriptase enzyme. So this with the help of this reverse transcriptase, the single-stranded RNA of this HIV is going to be converted into a HIV DNA. So this HIV DNA will then go and integrate with the host genome into the nucleus with the help of the integrase enzyme of the HIV virus. So once it is integrated with the host genome, what happens? The host will start producing the HIV particles. So it will result in the production of the HIV proteins. So the proteins will then come for assembly in the cytoplasm of the host cell. So once they are assembled, they will then incorporate with the host membrane and then get released into the external environment, forming the new complete virions. Okay. So normal CD4, this is what happens in the life cycle of the HIV. So normally CD4 count in the body is going to be 500 to 1000 per microliter. So whenever the CD4 count goes below 300, we are prone for getting the opportunistic infections. So when the count goes below less than 200, we are going to call it as acquired immunodeficiency syndrome. So when the count goes below less than 100, it is going to be, they are going to have an increased risk of an opportunistic infection with cryptococcus. So less than 50, you are going to have a CMV infection and also CNS neoplasms, lymphomas basically. Okay. So this again has been asked as MCQs. So the normal CD4 to CD8 ratio will be 2:1, but this is going to be reversed in HIV infection. Okay, so CD4 cells are being used up by the HIV, right? So CD4 cells are being lost. So CD8 cells will be much more higher than that of the CD4 cells. So normally in HIV infection, they undergo 3 phases. Initial phase will be the acute syndrome. As soon as they acquire the infection, there is an acute syndrome which will present with flu-like symptoms. Okay. Next, then go in for a chronic phase, which is the asymptomatic or the window period. Okay, they'll be there for the asymptomatic. Then comes the clinical AIDS. Okay, so only when they have this features clinical presentation, they are going for the AIDS presentation. Okay, so AIDS is when the CD4 count has gone below less than 200. So what are the clinical features of AIDS? So fever, persistent fever will be there along with diarrhea, and then chronic generalized lymphadenopathy, weight loss, and fatigue. Then they can also develop neurological disease, that is AIDS dementia complex. Then opportunistic infections they can develop. Then AIDS defining neoplasms. So what are the AIDS defining neoplasms? Only 3 things are called as AIDS defining neoplasms. The most common one of which will be the NHL. Okay, most common is the non-Hodgkin's lymphoma. Then we have Kaposi sarcoma. Initially it was Kaposi sarcoma which was the most common in neoplasm. Now it is NHL. Then cervical cancer, because it is going to be associated with HPV infection. Co-infection with HPV is going to result in cervical cancer here. So these 3 things are the ones which are defined as the AIDS defining neoplasms. Under NHL also, the most common will be a primary CNS lymphoma. Okay, the primary CNS lymphoma, which is basically of the morphology of the DLBCL, diffuse large B-cell lymphoma. Okay, so let's see about the opportunistic infections which we see in AIDS commonly. Most common infection is going to be the tuberculosis, but the most common fungal infection, if they ask, it is going to be the candidal infection. Okay, the most common ocular infection will be the CMV infection resulting in CMV retinitis. The other infections will be Cryptosporidium, Cyclospora, Isospora, Toxoplasma gondii, Pneumocystis jirovecii, then atypical mycobacteria like Mycobacteria aviums intracellular, there is MAC, then cryptococcal, histoplasma, and coccidioides, some fungal infections, then viral infections like cytomegalovirus, herpes simplex, varicella zoster, then JC virus. So all of these infections do not normally occur. They usually happen in immunocompromised individuals like AIDS infected patients. So let's see about other important MCQs related to HIV. So in HIV, the most common space occupying lesion in the CNS is going to be toxoplasmosis. Okay, it is just space occupying lesion in the CNS, it is toxoplasmosis. But if they ask for space occupying CNS tumor, in that case, it is going to be NHL, that is primary CNS lymphoma. Okay. The most common hematological manifestation in AIDS will be autoimmune hemolytic anemia. Dermatologically, we are going to have seborrheic dermatitis. Neurological manifestation is going to be AIDS dementia complex. Under renal, we are going to have FSGS. Specifically, we are going to call it as HIVAN, HIV associated nephropathy. That was a collapsing type of FSGS, remember? And the most common endocrine manifestation in HIV infection or AIDS is going to be lipodystrophy. So these again can be one-liners. So how do you diagnose HIV? Normally, we do a screening test with ELISA. So ELISA will come positive. So ELISA is the screening test, and the confirmatory test will be Western blot. Okay, Western blot is used for confirmation. And during the window period, these tests will come negative. So during window period, you are supposed to use a RT-PCR test to confirm the HIV infection. Okay. So now we are seeing about the immunodeficiency.